Hey, good evening, one and all. I am delighted that you are here tonight, joining me for this faculty program on teaching pharmacology, focusing on pharmacokinetics and pharmacodynamics tonight. And we're literally going to wait one more minute till we're at the top of the hour. Make sure everybody can get in here and get settled. I always appreciate what incredibly busy lives we all live, and so then we will get going. Okay, we are at the top of the hour, and welcome again. I'm Dr. Margaret Fitzgerald. I'm going to be teaching the program this evening, and which I hope will have some questions coming in and helping you out with struggles that you have with teaching pharmacology. Brian is on with us tonight to help us with technical issues. And what I'd like to do before, as we get going, is questions to Mr. Austin will go in the chat box, and he has already some information for you and some free resources to share with your students. And then if you go over to the top or the bottom of your screen, however it looks on your version of Zoom, there's an icon that says more that has three buttons on it. If you click on that, there's a Q&A box in there. And that's where I will take questions or comments directed to me in the Q&A box. So with that said, let's get going. Pharmacokinetics, pharmacodynamics, getting back to basic in choosing and prescribing medications. Little bit about my background. I'm Dr. Margaret Fitzgerald. I am the founder of Fitzgerald Health Education Associates, and I and my team have helped about 180,000 nurse practitioners achieve certification to date. My clinical practice has been in a federally qualified health center as a family nurse practitioner, where I saw everything that came through the door: pregnancy, the little ones, the ones in the middle, the older ones, and really honored with my long tenure there to see many, many, many three-generation families, a fair number of four-generation families, and even a five-generation family in my practice. And my practice was split up between primary care and same-day urgent care. And the reason I bother to give you that background is in case you've got questions along those lines with urgent care, et cetera, I can often help out with that. I'm on the faculty as an adjunct associate professor at Case Western Reserve, which in Cleveland, Ohio, which is where I did my doctoral studies. I sit on the editorial board of the NP Journal and Prescriber's Letter. And I'm also a member of the Pharmacy and Therapeutics Committee at Mass General Brigham Health Plan, which is a major HMO based out of Boston. And whenever I teach, and I know everyone on this program tonight is faculty, but whenever I teach, I'm teaching NP review, or I know I've got a lot of students in the audience, I always go over all of those uh, things that I'm involved in, professional activities, not to brag, but to give them an idea of what you can do with this role. And I'm sure that all of you have many activities you're involved in like that. And I always will tell them too, if you ever have a chance to sit on a pharmacy and therapeutics committee, grab that opportunity. It is absolutely eye-opening to see the process. And part that I'm very proud of, I'm the only nurse practitioner that sits on this committee, and I am the only primary care provider. And therefore, if they've got a primary care question, they turn to me as the expert on the panel. And you know what it is? It's simply an example of us as NPs taking our seat at the table where we belong. So disclosures, no real or potential conflict of interest to disclose, no experimental or investigational use of drugs or devices will be presented, and any off-label use will be identified as such if discussed. I'm almost positive there's no off-label use in this particular program. So upon completing the learning activities, the participant will be able to describe the importance of learning PK/PD principles in NP education, identify the basic principles of drug absorption, distribution, elimination, and their relationship to clinical pharmacokinetics, and recall the importance of drug bioavailability, half-life, clearance, steady state concentrations, Tmax and AUC, area under the curve in clinical practice. And references will be included within the presentation and at the end of the presentation. So so before I go any further, why did I put this series together? Because this is part one of a multi-part series. And part of that is because I have been privileged to teach NP review to so many people. And I will have people, the NP new grads coming in, and I very, very, very recently, because it's springtime, I taught an in-person review course in this month of May, in person, and one online review course. And I've got another online live stream review course coming up in, I think, like 2 more weeks, something along those lines. So in any event, what do I hear from people? What I hear is the things that frighten them and give them pause about their new role is the pharmacology part and lab interpretation. Those are the two big things that I hear the most about. And part of me wants to say, remember, it all starts with the health history and the history of present illness. So you want to make sure that you're working on those. But again, because this being a prescriber is part of their new role, that some of the other things that they should actually carry over from their RN role, like knowing how to take a history, therapeutic communication, they're sometimes forgetting that they've got that in the background and how important that is. And I will say, the two areas of pharmacology people will tell me right off the bat they're struggling with the most are antimicrobials, and that will start in session 3. And drum roll, please, I believe no big surprise to anybody, the drugs for the treatment of type 2 diabetes, and that's what we're doing in the next session. But what we have to do is start off and make sure they've got that really good grasp of the key pharmacology principles. And what happens in most NP programs? People take patho and pharm before they realize how much they need patho and pharm. Okay, I've taught pharmacology for decades, and that people are where not all schools are sequenced like this, but many schools are sequenced that way, where the 3 Ps are foundational, and then you start in your more clinically oriented classes. So let's do a quick review of pharmacology principles. And by the way, feel free if what you want to do is share the PDF handout with your students, whatever, this is all good. This is all good. So pharmacodynamics, it's a study of the biochemical and physiologic effects of drugs. And this is the way I will describe it to people, and they seem to grab onto it. It's what the drug does to the body and or disease. So it includes the drug's mechanism of action. And they always need to know how a drug works. Okay, it's not just adequate to know that triptans are used in migraine. Obviously, they need to have an idea of how they're actually working. So, quick question, and this is something that even practicing clinicians usually get wrong. The pharmacodynamic profile of a medication is unchanged over the lifespan. So I'm going to let you answer this on your own here, whether you think that is true or false. And the answer to that is it is true. The pharmacodynamic profile of a med is unchanged over the lifespan, which is a fancy way of saying the following. The way a med works on a 1-minute-old baby is the way it works on a 101-year-old. Okay. Pharmacodynamics knows no age. Okay. So and again, that is such a key principle to keep in mind. Okay, pharmacokinetics, the ADME mnemonic, what the body does to the drug. Absorption, whether it's through the skin, lungs, GI tract, parenteral. One concept as people are transitioning from the RN role to the NP role, and certainly not all NP work is done in the outpatient setting, but the vast majority is done in the outpatient setting, where we're giving PO medications rather than parenteral medications. But let me just mention, like in the world of antimicrobials, okay, antibiotics, there is virtually no clinical difference in outcomes from oral antibiotics to parenteral antibiotics as long as the gut works. As long as the gut works. And so what a lot of new NPs come to the role, or NPs students come to the role, is they've seen almost all parenteral antimicrobials, and they view them as inferior to oral. Doesn't work. Nope, they're equivalent. Distribution. This is through the body, especially to the needed site of action. That's a key principle to drive home too, because distribution of a drug and getting it out to the site of action is often dose dependent. And so I know I'm kind of picking on antimicrobials here, but I'll often say to people, do not practice antimicrobial homeopathy. Prescribe the highest safe dose for that person and that indication, because what you want to do is get enough of the drug distributed to the site of the infection so that you actually kill the bugs and not just tease them. Metabolism, which is a term that we still hear bantered about, drug metabolism. The more contemporary term for that is drug biotransformation, which is changing the drug from one form to another, liver, GI tract, and other place, but the liver is the big part. And then elimination, of course, through the kidney, the GI tract, and others. The kidney rules the roost here on drug elimination. So true or false, age and gender significantly impact a drug pharmacokinetics. So what do you think of that one? And that, of course, is true. But a few things to keep in mind. Most of you are family NP faculty, and I know that without even looking at the numbers. And that is because, what is it, like 2/3 of all NPs who graduate are family NPs, and everything else is the other 1/3. And so quite often what I will see is students saying, oh, but I'm so nervous prescribing a medication, even like amoxicillin, to a 2-year-old with an acute otitis media who does qualify for antimicrobial therapy. And I'm afraid I'm going to hurt the child or whatever. Remember, the little ones don't suffer with liver disease, kidney disease, etc., like the older folks do. And by the time a healthy child is around 6 months old, they are outstanding drug metabolizers. In fact, they're so darn good. That's why sometimes we will see doses of certain things, like antimicrobials, look alarmingly high in a younger child when compared to the adult dose. Okay. Fick's law, and how do drugs move from point of ingestion to point of action? And Fick's law says it's a tendency for molecules to move in the direction from higher to lower concentration via random molecular motion. And this typically occurs across a membrane or a permeable barrier. And this is the actualization of Fick's law is how most drugs move from one point to another. what are some examples of the permeable membranes? One of them is the blood-brain barrier, mammary alveolar tissue, so into breast milk, placenta, cell membrane, and vessels. So drugs that are lipophilic, lipo, fat, philic, loving, fat loving, are drugs that get through the blood-brain barrier with ease. They get through the mammary alveolar tissue with ease. They get through the placenta with ease. And when you say, great, now we have to memorize which drugs are lipophilic. If a drug makes somebody excited or sedated, it's highly lipophilic. Because then if it makes the person excited or sedated, caffeine, sedated, diphenhydramine, Benadryl, then that means it is a super lipophilic drug because it gets through the blood-brain barrier. Then it will get through the mammary alveolar tissue easily. It will get through the placenta easily. And I find that something that people go like, oh, good, I'm going to remember that now about what drugs tend to be more lipophilic. But I will tell you, there are a lot of drugs that are lipophilic just so that they get through the gut wall, and then they're biotransformed to hydrophilic, usually by cytochrome P450 isoenzymes, which I will cover in more depth in another one of these programs. Cytochrome P450 isoenzymes biotransform from lipophilic to hydrophilic so the kidney can kick the med out, and also so that it will get through cell membranes to where it needs to work and get out of the vessels to where it needs to be, okay? So passive diffusion, as I said, that's going to be the most common way that drugs go from one point to another, and that's a basic absorption principle. And okay, and this is a question that I will hear from NP students or new grads. In my outpatient NP role, I'm seeing that most meds are given PO, where many are given IV inpatient. And so just a basic rule, the gut needs to work to give meds PO, but some meds cannot be given orally. And, you know, Pharmacology 101 says if the gut works, use it, okay? Your patient needs to be treated for a community-acquired pneumonia. Okay. And this person is fine and dandy for outpatient treatment. Has a CURB score of 1, so fine for outpatient treatment. Lives with another human being who's pretty attentive and will take action if the person with the pneumonia suddenly doesn't do so well. And so that person could be started on either a fluoroquinolone antibiotic, or let's go to something more realistic, something like doxycycline with a second generation cephalosporin, like a ceftonir, okay? So in the inpatient setting, what you probably would see is IV ceftriaxone plus IV azithromycin, particularly if the gut's not working well. And then in the outpatient setting, we can do either PO, azithromycin. I prefer doxy. In that case because of the QT prolongation that can go along with azithromycin use, and the ceftonir PO, which is the equivalent of ceftriaxone. So yes, we do have equivalent PO meds to the IV meds that they've seen given, but some meds cannot be given orally. It doesn't matter what we would ever do to insulin. You know, put it in a little wrapper so that the stomach acid doesn't destroy it. Insulin will never be given PO. There are also, sticking on the subject of antimicrobials, some that are not given they're given IV for certain infections, but they can't be given PO. So what's the deal with vancomycin? Okay. Inpatient IV vancomycin is commonly prescribed for suspected or confirmed MRSA skin and soft tissue infection, but you can't take somebody and then say, okay, you're ready to go home now. We're going to DC your IV vanco and switch you over to PO vanco. Won't work, won't work. And why won't it work? So, which of the following reasons that PO vanco is not used for the treatment of skin and soft tissue infections with suspected MRSA, while IV is sometimes prescribed? And would it be the pharmacodynamic differences between oral and parenteral? Mm-mm. Because pharmacodynamics, what the drug does to the body, what the drug does to the disease. Pharmacodynamics between PO and IV, same. Okay? So it's not pharmacodynamics. And what about vancomycin's qualities that influence the drug's pharmacokinetics? And the correct answer is the second one there. It's vanco's pharmacokinetics do not allow this drug to be used as a PO drug when what you're trying to do is get it to a suspected MRSA, suspected or confirmed MRSA skin and soft tissue infection. Okay? So, is there a difference between the two? Yes. What it is the molecular weight of vanco is gigantic. It's almost 1,500. Any drug with a molecular weight of greater than 1,000 cannot be absorbed through the GI tract. However, there is a vanco form, a vancomycin hydrochloride, excuse me, that is used for the treatment of C. diff-associated diarrhea and enterocolitis caused by Staph aureus. Okay? So there is the occasion. I'm going to tell you it's not the preferred drug for the treatment of C. diff, but it's one of the drugs that's available. So on rare occasion, you will see PO vanco used. But it's a really specific reason. And the reason for that is since it's C. diff associated diarrhea and enterocolitis caused by Staph aureus. By the way, the latter is pretty uncommon. C. diff, unfortunately, is not that uncommon. And why is it okay to give vanco then with C. diff? Is because the only place the vanco needs to work is in the lumen of the gut. That's it. That's it. And by the way, like I said, you have fair game. Take any of these examples. If you find these helpful, share them with your students. So, absorption principles, why can't we give these drugs PO even if we could protect them from the GIPH, which would probably chew these all to bits? Unfractionated heparin has a molecular weight of 40 to 50,000. Insulin has a molecular weight of 5,500. Even low molecular weight heparin, the kind that's most commonly used, has a molecular weight of 8,000. So you might say that why was it called low molecular weight heparin? It's because unfractionated has a molecular weight of 40,000 or more. So in comparison, it is pretty low molecular weight. So for drug oral absorption, proper molecular weight, less than 1,000, almost everything that we give commonly is going to have a molecular weight of around 250 to 600. Okay. That's in the unit of measure for molecular weight is Daltons, which you'll every now and again run into a drug that will say molecular weight is 250D with the letter D after it. That stands for Daltons. And it needs to be lipid soluble, as I mentioned, to get through the gut wall. Also, where are most drugs absorbed? They're absorbed in the small intestine. And the reason for that is that huge surface area of the small intestine. And of course, you need a functioning GI tract. I'm going to let you in on a little secret here. You know those triptans that are in the oral dissolving tablets? None of that is absorbed in the mouth. None of it. Where is it absorbed? Duodenum, small intestine. So why bother, if you will, with an oral dissolving tablet of a triptan? You might have somebody having a migraine who is so nauseated that even taking a little bit of water to get a pill down, the person fears they're going to trigger vomiting, and the poor soul feels miserable enough anyway anyway. So that's why sometimes the oral dissolving tablets is a good idea. And just one other thing that that helps with drug absorption. Liquid drugs orally are absorbed a wee bit quicker than tablet form because tablets have to sit in the stomach and dissolve. It doesn't take that long, but they do need to sit there for a little while and break down. And that's one reason why with a lot of my patients with migraine, I'll use, particularly those that are really sick to their stomachs, but they're not actively vomiting with their migraine, the oral dissolving triptan and 600 milligrams of liquid ibuprofen. Most people can get that down. Both of them kick in pretty fast and they feel much better, much quicker. I'm going to talk a little bit more about the triptans later on in the program, and I'll give you one of the rules I teach people when I teach NP review about treating migraines, and the fact that triptan monotherapy isn't a particularly good idea. All right. So what's the pro and the con between parenteral and PO meds? PO meds, less expensive, don't require provider assistance in delivery, widely available. Con, it does require a functioning gut, and as I mentioned, not all meds are available in PO form. Parenteral meds, the con, more expensive, provider assistance for delivery. I should clarify that. Obviously, there are a lot of people self-injecting things like insulin, GLP-1 agonists, etc. But more when I was thinking about like parenteral antimicrobials, limited availability, not everything's available injected. Pro, usually more rapid onset of action when compared to PO. Well, just a moment ago, I was talking about antibiotics doing pretty well PO versus parenteral. If you look at the fluoroquinolones within 2 hours of an IV versus a PO, you've got similar circulating levels and drug tissue levels of the fluoroquinolone. So yeah, there might be a little lag, but there's usually not a lag that is of clinical significance. And it's able to use when the gut is not functioning, of course, when there's nausea, vomiting, or last but certainly not least, altered level of consciousness. So here we go. You have a patient who has acute migraine without red flags. So there's no new onset of hemiparesis or major visual change, blinding headache that began all of a sudden that might make you think of a subarachnoid hemorrhage. So no red flags. In other words, this is this particular patient's migraine. And she's reporting to you, as you can see here, same headache over and over and over again. So remember, migraine is one of the most common recurrently painful conditions, one of the most common chronic pain conditions that we see in practice. We don't often think of headache as a chronic pain condition, but it is. A 28-year-old woman, premenstrual pattern to migraine, normal neuro exam except photophobia, phonophobia, mild nausea without vomit, same headache over and over and over again. All right, so this is her headache. And which course of therapy will provide improved outcomes at a lower cost? So would it be she shows up to the emergency department and get for parenteral meds, IV fluids, and also IV meds? And so, you know what? Some people with migraine will need to go to the emergency room. One of the key points, or urgent care, something along those lines. But given we know this is a chronic painful condition, one of the very, very best things that we can do for people with migraine, or for that matter, tension type headache, is teach them how to self-manage at home with oral meds. And so it would be a migraine specific PO med, like a triptan. And the triptans are pretty drugless, but the prices have come way, way down because they've been generic for so long now. And an analgesic starting at the headache onset. So this is how I handle it. Whatever triptan this person's insurance will pay for, that's what I prescribe. And I will choose one of them with a rapid onset because they do not all have a rapid onset. They don't. And also give an analgesic agent and start the investigation for headache prevention medications, okay? So remember, triptans are triptans. They all work the exact same way. They are drugs in a given class. And this is something I find people struggle with. They don't appreciate that drugs in a given class all have the same pharmacodynamics, but they could have very different pharmacokinetics. So get that migraine specific PO med on board at the beginning of the headache, and then also add an analgesic. Because here's the thing, when I look at what she's saying, photophobia, phonophobia, headache, mild nausea, the triptans do a better job at getting rid of the non-pain part of the headache. The photophobia, the phonophobia, the nausea, the I can't think straight. They do a better job with that than they do of getting rid of the pain. But if you boost them with an analgesic, those two together it's inexpensive, it's safe, and it allows for self-management. So headache prevention meds, then have that discussion with the patient. Okay. Let me just see if any questions came in. Oops, sorry about that. I think I accidentally unshared. So let me just go back here. What I was trying to do here was just go over and see if there were any questions. Okay, no questions. All right. Area under the curve, the AUC. This is the area under the drug plasma area under the plot of the drug, try it again, area under the plot of the drug plasma concentration against the time after a single dose of drug administration. Okay, what we're looking at here, now remember, this is single dose. And you'll see that we have an AUC that's orange and an AUC that's blue, right? And let's say that this is a drug for acute pain, right? It could be something as simple as ibuprofen, right? And these two AUCs represent two different people. The orange curve represents two Tylenol or two ibuprofen, 400 milligrams of ibuprofen given to an 18-year-old with a sprained ankle, right? And what you're going to hear from that person is kicked in really fast. They got pain relief really quickly. And then the pain relief tended to wear off equally as quickly because they've got a little 18-year-old liver there. They've got 18-year-old kidneys. They're super, super drug metabolizers at that age. And that is why you'll tell you the dosing interval can be 6 to 8 hours. Okay. So that orange AUC, that's going to be the 6 hours. If you're lucky, they're going to get 4 to 6 hours of pain relief out of it, which is why, given my example of a sprained ankle, you want ice, you want crutch walking, everything else that needs to be done. Okay, you're going to do all those other things because you know the standard pain meds that we use, they're just not going to last all that long. Now, the blue area under the curve might be the same 400 milligrams of ibuprofen, even like a 55-year-old. So not that old, right? Reasonably good renal function, reasonably good kidney function, but doesn't have 18-year-old kidneys, 18-year-old liver. So the med takes longer to kick in, but it hangs around a longer period of time. And that person might say, yeah, sometimes, I've got this shoulder that bothers me and I take a couple of ibuprofen and, it helps, but it doesn't make it go the whole way away, but it does help. So that's why you can use the exact same med one more time. The pharmacodynamics are identical, but you're going to get two very, very different pharmacokinetic results from it. And the area under the curve is so variable according to age, birth, sex assignment, a bazillion other things. So Tmax, this is time to maximum drug concentration observed. Cmax is maximum or peak concentration of the drug observed over its administration. If you remember those two peaks that I just showed you with the area under the curve, I'm getting some wonky internet signals here, is that the Tmax was the time till they hit the peak. The Cmax was how high the concentration was. So, clinical significance of Tmax versus Cmax. Tmax and Cmax are usually when you will get the maximum drug effect. And that's a really, really helpful thing to keep in mind, to have in your armamentarium for prescribing. And what else? What else at Tmax and Cmax? You're going to get maximum clinical effect. Okay, we know that. You're also going to get maximum adverse effect. So if this is something that tends to, a drug, whatever it would be, that tends to make people sleepy, that's when they're going to be the sleepiest. If it's a drug that tends to give people nausea, other than a localized GI issue, more a central issue, that's when they're going to be the most nauseated. If it's something that makes people jittery, that's when they're going to be the most jittery. And I will counsel patients about this all the time, about looking for that and saying, this is a med that can make you feel a little bit wound up, and you might notice that a couple of hours after you take it, or it's going to make you a little sleepy, so really be aware of that. So these are the pharmacokinetic. Insulin is insulin. It all works the exact same way. So pharmacodynamically, insulin is insulin. But this gives you the idea of like glargine and detamere. Glargine is Lantus. Detamere, I don't remember the generic name of that. But those are basal insulins. And what they are is they're in the background all the time, acting like the healthy pancreas. Healthy pancreas in a person who does not have diabetes as basal insulin, the other 50% as boluses to cover the carbs in a snack, a meal, whatever it would be, right? So the RA means rapid acting insulin. So the insulins that kick in really, really quickly. So what's the potential problem when insulin is at Cmax? And the potential problem, of course, is hypoglycemia. That's when hypoglycemia is most likely to occur. One issue I see people who are new grads or getting ready to graduate is they have seen in their clinical practice as an RN what's commonly called sliding scale insulin, which technically is not sliding scale, it's technically correction insulin. And I've seen them attempt to mimic this outpatient when patients require insulin. And that is not advocated by ADA or any other group to be chasing down elevated blood sugars. It just isn't. And the rapid acting insulins kick in so quickly. That's why they're either given just before eating or with the first bite when the person actually knows what they are going to eat, but not waiting until 1 or 2 hours later and then try to chase down that hyperglycemia. So insulin PK versus PD differences with more difference than any other with the insulins. But pharmacodynamics, remember, a given class of drugs, they all work the exact same way. The beta-2 agonists all work the same way, but pharmacokinetically, they're all over the place. We've got the short-acting beta-2 agonists, we've got the long-acting beta-2 agonists, etc. All right, so clearance. This is the volume of blood fluid from which the chemical is completely removed by biotransformation and or excretion. As I mentioned before, for a drug to be excreted via the kidneys, it needs to be water soluble. Hepatic clearance, it can be fat soluble, but very, very few drugs are only acted on by the liver to get them out of the body. So what do you think the body wants to do to drugs? Do they want to hang on to these foreign substances or get rid of the invader as quickly as possible? And so biotransformation sites that are um, um, in the body, the liver is the big one. And I mentioned that before. Now, less active but clinically important include the GI tract, the lung, the skin, and the kidney. And interestingly, even the placenta in the third trimester of pregnancy will often will often provide a little bit of drug biotransformation. So right in front of me, I have one male, one female. And this is their birth sex assignment, okay? They're inches tall. They're both 45 years old, okay? And let's just say, that they both are in similar states of health, similar degree of physical activity and physical fitness. So out of the two of them, remember the only thing difference between them are their birth sex assignment. Who has an exact same size, exact same height? Who has the bigger liver? The male. Therefore, who has more hepatic enzymes? The male. Who accounts which birth sex toxicity? You guys are smart, you're catching on here. It will be the female who has the bigger kidneys. The male who has more body fat. It'll be the female. So lipophilic meds will hang around longer in females than in males. Who has more lean muscle mass? And let's say that they are really physically very equivalent in their degree of fitness. It will be the male because of the impact of the androgens, and androgens help with muscle building. So this is why we get a recommendation like this. And this is nothing new. I believe you folks are all aware of this, but to make sure your students are aware of it, is Zolpidem, a sleep drug, therefore fill it, correct? And it's going to go up through that blood-brain barrier and help put the person to sleep. So this was an advisory that came out from the FDA a few years ago of the risk of next day morning impairment after the use of insomnia drugs and recommending lower doses of certain drugs containing Zolpidem. So this is what happened was the dose of Zolpidem, Ambien, was lowered from kind of more or less any adult could use 10 milligrams, from 10 milligrams to 5 milligrams for women, and either 5 or 10 milligrams for men. Now, to prescribe a drug like Zolpidem, we're not talking about this. We're talking more about pharmacokinetic, pharmacodynamic principles. And that if it is Zolpidem extended release dose, 6.25 milligrams for women, and either 6.25 milligrams or 12.5 milligrams for men, controlled release formulation, which in essence gives like a little extra boost at about 2 o'clock in the morning if it's taken around 10 o'clock at night, that there was an additional warning about next day performance issues because more of it hangs around, and doses higher than that should be used with caution. And it's just a good reminder that sometimes what will happen with medications is they've been around for a while, and then we get advisories like this about pulling back on the dose here. So first pass effect, aka pre-systemic elimination. This is biotransformation and or excretion of oral drugs by hepatic mechanisms. And this occurs before the drug enters the GI tract, and then it's transported to interact with receptors in target tissues. In other words, where it's going to work. And drugs absorbed by the GI tract pass through portal venous system, then on to the liver, and finally to systemic circulation. An extensive hepatic for metabolism or extraction results in minimal drug delivery to systemic circulation under certain agents. So true or false, drugs with a large and pharmacologic effects comparing oral versus IV or parenteral administration. And that is true. That is true. So let me give you an example comparing the oral versus the parenteral drug. Sumatriptan, trade name Imitrex, oral, it's bioavailable, oral, the doses is 25 to 100 milligrams. Don't ever give anything less than 50. It just doesn't work as well. Okay, bioavailability is 14%. Okay, which means most of it is picked up by hepatic first pass effect, and the liver just tosses it out the door, and it's not available. Parenteral is only 6 milligrams because it is 94% bioavailable when it's given in a shot. And I find a lot of providers don't even know there is an injectable sumatriptan. There is, and it's really, really good. It's a great choice for people whose migraines go from 0 to 1,000 in like 5 minutes. You know, they have that really rapid onset migraine. Levofloxacin, Levaquin, community-acquired pneumonia dose, bioavailability for both of these, 99%. So 750 PO, 750 IV, right? And when you have drugs with high bioavailability, you'll see that PO and that IV dose be really similar. Okay. And bioavailability, better defined, is the percentage after PO administration of a given dose form, typically a different clinical effect from similar doses. Lower bioavailability equals higher hepatic first pass effect, higher bioavailability, lower first pass effect. And when you're talking about statins, Simvastatin has low bioavailability, higher hepatic first pass effect, and atorvastatin, higher bioavailability, lower first pass effect. So when we get down to it then, a statin is a statin because pharmacodynamics are all the same, but atorvastatin is listed as one of the statins that we can use to get to high intensity statin therapy. Simvastatin is only listed for moderate intensity statin therapy, right? And bioavailability is dependent on the route of administration. IV, it's 100%. IM or SC, 75 to 100%. PO, it could be as low as 5% to nearly 100%, depending on hepatic first pass effect, and of course, could be incomplete absorption. What about other routes of administration? Rectal can be 30 to 100%. Been there, done that. We've seen the rectal med kind of ooze out of the anus. Yep, just lost drug, but if it's held in there, it's a great, great drug administration. Inhalation, 5 to 100%. Drug is lost. Dermal meds, rectal meds, inhalation meds, IV meds generally are spared hepatic first pass effect. So half-life, this is the time required for the amount of the drug in the body to be reduced by 1/2. It's also known as the elimination of the biologic half-life. And you need 3 to 5 half-lives of a drug on board to reach steady state, 3 to 5 drug-free half-lives to eliminate the drug from the body. That last little nugget about 3 to 5 drug-free half-lives to eliminate the drug from the body is a wonderful prescribing tip to share with your students, because I'm making this up off the top of my head. A patient is on a drug with a half-life of 24 hours. They're having a not dangerous, but a pretty significant adverse effect from the med. And the patient comes in and says, "Ooh, I want off of this med." And it has a 24-hour half-life. You could say, "Oh, you took the pill today? You took the medicine today?" "Yes, I did." "Okay, in 3 more days of not taking the medicine, almost all of that medicine will be out of your body. And so 3 more days, you're going to feel better every day without it." But it also gives patients a timeline that they will know, they will know that the drug will be gone shortly. So here's one way to remember this. Drug-free half-life. And one drug-free half-life, 50% of the dose is gone. So you could check effect. Tomorrow, by this 24 hours after you took the med, you're going to start feeling better. But then 2 days from now, you're going to feel that much better. By 3 days, it's really going to be gone. So 2 half-lives of a drug is 50% of 50%, or 25% left. 3 half-lives is 50% of 50% of 50%, or 12.5% of the original dose left. By then, unless the drug was taken in overdose, it probably is so little of the drug left, it's not clinically significant. And then when you get down to 5 drug-free half-lives, you're down to 3.125% of the original dose is left behind. So, true or false? The half-life of a medication is a predictable number regardless of a patient's age, birth, sex assignment, and overall state of health. Oh, that is a big false. And it's typically the half-life is increased in older adults, usually fairly short in children when compared to even younger adults, for the reasons I mentioned before. They've got these busy little livers. All right, are there other influences to drug half-life? And one of them is zero-order kinetics. And this is the elimination of half-life influenced by the amount of drug given on board. More drug, longer time to offload due to the elimination process is saturated, whether that's cytochrome P450 isoenzymes or the like. Not all drugs have an influence with zero order kinetics, but with zero order kinetics, the rate of elimination varies by elimination saturation. It can include drugs like aspirin, warfarin, phenytoin. Okay, so you can see all older drugs, they're sometimes still used, but not day-to-day drugs anymore. First order kinetics, which is the majority of drugs, acetaminophen, Topamax. So that you see, and what I'm trying to do there is just compare one anti-epileptic drug to another, one anticoagulant to another. I know technically that warfarin and apixaban differ in a number of different ways, but I'm just using that as kind of a therapeutic category. And then aspirin versus acetaminophen for an analgesic, right? So statin versus statin, rosuvastatin has a really long half-life, 20 hours, and bioavailability of 20%. And that's the longest half-life, the longest bioavailability, the highest bioavailability of any of the statins. And I'm going to compare that to atorvastatin with a half-life of 14 hours and bioavailability of 14%. That's why rosuvastatin and atorvastatin are the only two statins listed as acceptable for high-intensity statin therapy. And then if you look at simvastatin, half-life 1 to 2 hours, it's gone in no time. Bioavailability is less than 5%. Pravastatin, another older statin, 1 to 2 hours for half-life, 17% bioavailability. So this is a nice little table too to share with your students on statin versus statin. It also includes the trade names because, patients are more likely to say I'm on Crestor, not that I'm on rosuvastatin. A couple of really important parts with this table. One, as I was saying, statin. Say that again. I got a little weird internet signal. That a statin is a statin is a statin by pharmacodynamically identical, but pharmacokinetically really different from one another. And one thing that I want to point out to you, and let's look at Lipitor, atorvastatin, just because it's so commonly prescribed. At 20 milligrams of Lipitor, you're going to get a 46% lowering of LDL, okay? At 40 milligrams, you're going to get a 51% lowering of LDL. That when you double the dose of a statin, you do not double its LDL lowering capability. It's somewhere more around like 3% to maybe 6% additional LDL lowering. So you can see that it's not a perfect linear type of a correlation there. So with that though, and this is a prescribing tip that a lot of people are unaware of, is which statins are best taken at dinner or bedtime. And that's going to be simvastatin, pravastatin, and lovastatin. Why? Because we make LDL during the overnight hours. Which statins can be taken any time of day? Matters not, because they have long half-life and they're going to hang around for a long period of time. And that's atorvastatin and rosuvastatin. And why? Because of the pharmacokinetic principle of shorter versus longer half-life, and LDL is produced in higher amounts during the overnight hours, okay? And I could see some questions have come in, and what I want to do, I want to get through this material and then we'll take the questions. Does the drug effect, though, exceed the 3 to 5 half-lives? Aspirin has a half-life of 15 minutes, but its effect on platelet function is 8 to 9. Any platelets formed while the aspirin was on board have a permanent effect on their function for the lifespan of the platelet. So, and the platelets live about 8 to 9 days. Now, one aspirin, 1 day okay? That will impact only the platelets produced during the time that one aspirin was on board. But what do we see in contemporary practice is we see people go on chronic low-dose aspirin therapy, and therefore the aspirin's on board all the time. And that's why there is that 7 to 10 day advice on discontinuing aspirin prior to elective surgery. All right, back to triptans again. And here are 4 different triptans. And remember, a triptan is a triptan is a triptan. They're all going to work the same way. We've got naratriptan, sumatriptan, frovatriptan, zolmitriptan. And what you will notice here with naratriptan, looking over to its half-life, it's 6 hours. But look at its onset of action, 1 to 3 hours. Let's compare it to sumatriptan. Onset of action, 30 to 60 minutes. Half-life is 2 hours. So let's quick do the math. If somebody took a tablet of naratriptan, Emerge, the medicine's going to still be circulating like 18 hours after the dose. Somebody takes a dose of sumatriptan, the med's gone in 6 hours. Frovatriptan takes 2 to 3 hours to kick in, but hangs around for 26 hours. Zolmitriptan has very similar pharmacokinetics to sumatriptan, right? But one more time, a triptan is a triptan is a triptan. But would some triptans be better? So let's talk about which triptan will likely fail if, and which one will likely be helpful if. Let's say the patient has a really rapid onset migraine. 12 noon, no migraine, 12:05, ooh, this is a winner, okay? They've got a really rapid onset. So if they have rapid onset migraine and you prescribe naratriptan or frovatriptan, what you would say is, oh, your headache started at noon? Let me see, about 1 to 3, and you're going to take the medicine now at 12:02. At about 1 to 3, you're going to start feeling better. It's going to take a few hours for the med to kick in. That's unacceptable, right? With rapid onset migraine? Very unacceptable. But sumatriptan, zolmitriptan would be helpful because boom, boom, they kick in quickly. But there are people who have slow onset migraine that lasts for hours, i.e. premenstrual migraine or menstrual migraine. Sumatriptan, zolmitriptan, they'll tell you, I have to just keep taking it over and over and over again. And my naratriptan or frovatriptan, for somebody like that, it is like a miracle. It really is. So knowing the pharmacokinetics is really, really helpful. So a few pharmacodynamic principles here. The majority of meds exhibit their effect via interaction with a macromolecule or a receptor site. And what are these receptor sites? They're proteins that selectively allow a substance to bind and cause action. And the receptor sites have different electrical charge, different sizes, different shapes. And a few of the target receptors that we're often looking at are the beta 1, beta 2, and alpha 1 receptors. So beta 1, quick and dirty way of remembering that, they're in your one heart. Beta 2 in the airways to the 2 lungs and in the 2 arms and the 2 legs. And alpha 1 are in the vascular bed. So cardioselective beta blocker is going to work on beta 1, but not beta 2. Non-cardioselective beta blocker, like propranolol, will hit beta 1, but it's also going to hit beta 2 receptor sites in the 2 arms and the 2 legs, okay? So drugs that are agonists bind to a receptor site and cause an effect similar to an endogenous compound. And so the name would reflect the receptor. So beta 2 adrenergic agonists are drugs like albuterol, solmeterol, and others. They activate the beta 2 receptors like the catecholamines do. And next, net result is bronchodilation. But why do people shake if they overdo it with a beta 2 agonist? because the beta-2 agonists, yes, hit the airways, but particularly when used in excess, they can cause shakes because of the beta-2 receptor sites in the arms and the legs being affected. Most of the time, people don't appreciate it in their legs, but they'll go like, "Ooh, look what this drug is doing to me." Like if you're giving them nebulized albuterol. An agonist example would be a drug like pseudoephedrine because it hits alpha-1, beta-1, beta-2 agonism. So because of the alpha-1 agonism, push up blood pressure, one reason we tend not to use a decongestant like pseudoephedrine in people with high blood pressure, elevated heart rate, mostly if you overdo it with the pseudoephedrine, because that's the beta-1 agonism and mild bronchodilation, but it's nothing compared to a beta-2 agonist. But it would be the impact on the beta-2 receptor sites. An antagonist is a medication that blocks the receptor site and that keeps the receptor site from being activated. So that would include drugs like anything that we talk about as being a blocker. Alpha-1 adrenergic prostate-specific alpha blocker is the drug tamsulosin Flomax used to treat BPH. Beta-1 adrenergic antagonist or a blocker, beta-1 cardioselective beta blocker, would be like atenolol, metoprolol. Metoprolol is one of the most commonly prescribed drugs in the United States. And the non-cardioselective beta-1, beta-2 adrenergic antagonist or blocker would be like the drug propranolol. So here's nice little apply this to a clinical scenario, because most people have heard about this, that there are certain meds you can take if you have situational anxiety like stage fright, okay? And and beta blockers will do this, but if what you're trying to do with stage fright is get rid of the shakes and a tremble in your voice, what do you think you want to go with? A cardioselective beta blocker or a non-cardioselective beta blocker? So which one would be used? Would it be atenolol, propranolol, or metoprolol? And propranolol is the correct answer. Also, sometimes in the treatment of just plain anxiety disorders, propranolol is considered to be a therapeutic adjunctive agent if there's no contraindication. But what beta, so we often hear, okay, don't use beta blockers in people with lower airway disease like COPD or asthma, but which beta blocker therapy is considered to be acceptable in lower dose in the presence of COPD, particularly with concomitant cardiovascular disease like heart failure, angina, that type of thing? Would it be A, propranolol, B, metoprolol, C, naldolol? So what are you going to do then? You're going to go with low dose cardioselective, the beta-1 blocker there. And I will tell you that there are other cardioselective beta blockers. Metoprolol has been the best studied for this purpose, and that would be definitely the one I would go with. All right, this is a pharmacodynamic drug interactions, which are not very common. A 28-year-old woman with migraine on a non-cardioselective beta blocker, propranolol, which is not FDA approved for that purpose, but is in the migraine treatment guidelines by the American Academy of Neurology, okay, for headache prophylaxis, now has acute bronchitis. She was given albuterol to help with bronchospasm that's going along with her acute bronchitis, and she states, the inhaler's not doing anything. I was up all night long coughing. All right. So this is a rare pharmacodynamic drug interaction. So the propranolol has blocked her beta-2 receptor sites, so it's sitting there. And now the albuterol can activate that beta-2 receptor site and cause the bronchodilation. So would there be a workup workaround on that. So what's a therapeutic alternative to albuterol in the presence of non-cardioselective beta blocker therapy? Would it be A, ipratropium bromide via MDI? That happens to be Advisor. C, salmeterol via MDI or fluticasone via DPI. Now, this is an example of a question that will rather vex the newer clinician, but it really drives home an important point. So first of all, what I would do is if you want to use this with your students, be my guest. Again, you have my permission to do that. If you look at B and C and you look at the suffix of those drugs, they're both terols. Okay. So that tells me they're beta 2 agonists, and she didn't have clinical effect with one terol already, albuterol. So trying her on another one of the terols, the beta 2 agonists, it's like just, you know, moving things around. You're just trying another one, another drug in the exact same class. Not going to get you anywhere. Okay. So that's the good elimination, B and C. Okay. Then if you look at D, it has the ONE suffix on it, which tells me it's likely a steroid. And fluticasone is actually Flovent. When you squirt it up your nose, it's Flonase. So it is a commonly used corticosteroid for the treatment of things like squirted up the nose, allergic rhinitis, inhaled in the chest. One of the choices for an inhaled corticosteroid. I'm going to do a whole session on asthma, one of these. So we'll get more into the smart therapy and everything there. So you got rid of B, you got rid of C. D is a whole other drug class. She needs bronchodilation. Giving her an inhaled corticosteroid today is not going to do her a lot of good. So the correct answer is A, ipratropium bromide or Atrovent, because that is a muscarinic antagonist. And what it does, it's in the same class of drugs as drugs like tiotropium bromide, Spiriva. There are a myriad of them on the market now. And tiotropium bromide or Spiriva is a long-acting muscarinic antagonist. Ipratropium bromide is a short-acting muscarinic antagonist. What it's going to do is cause bronchodilation through a receptor site other than the beta 2 receptor sites. And that will help her out with her cough. So when the propranolol is discontinued within 3 to 5 drug-free half-lives, the albuterol use will once again be effective for bronchodilation. And the answer is, of course, true, because the drug that's blocking the beta 2 receptor sites will be gone. So in conclusion, teaching pharmacology to students is a tremendous privilege. And it's a great challenge, isn't it? But I thank you for what all of you do for the benefit of your students, and I'm happy to take questions now. So wonderful presentation. Oh, thank you. I find many students memorize material rather than understand concepts of pharmacology. Oh, preach it. Preach it. I always say to them is maybe memorize cranial nerves, okay? But just don't memorize anything else, okay? And rather than understand concepts of pharm when we're teaching a 10 or 15-week academic semester, which leads to superficial learning. What recommendations do you have to ensure we're equipping our students with core knowledge to be safe prescribers? Okay. I wish I had a really easy answer for that. But one of the things that I would point out when I have people coming to see me for NP review, and like if I'm in a room with them, and I recently had an in-person review course where I could tell for about 2/3 of the people, this was review. They were going like, oh yeah, yeah, yeah. I forgot I knew that. Yay, yay, glad I'm here, because I don't know, it was a topic they just haven't seen a patient in for a full academic year, or it was something you covered their first semester and they go, oh, yeah, 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 I just haven't thought about that. And then the other third is they're really struggling. And who do we tend to remember more? We remember our students who struggled more rather than the ones that just went off and lit up the world. Point out similarities to them. And I'm kind of, stepping on my own lines for what I'm going over to in a couple of weeks on the antimicrobial, or a couple of months, whenever it is, the antimicrobial presentations. When those start, let me correct myself, it's 2 months, not 2 weeks. Okay. So I find what people have not noticed is that what causes acute otitis media when it's bacterial? Strep, pneumo, H flu, Moraxella catarrhalis. What causes ABRS? Same. What causes COPD exacerbation when it is bacterial in origin? Same. What what causes some, but not all, community-acquired pneumonia? Strep, pneumo, H flu. Now, do you notice the same antimicrobials are coming up over and over and over again? And they'll go like, whoa, I never thought of it that way. So if you can encourage them to recognize patterns. Next week, when we get into the diabetes drugs, you're going to see that I organize those drugs generally a different way than they've ever looked at before. And therefore, they look at them and they go, oh, okay, now I know. Do I need an insulin sensitizer, an insulin releaser, or a glucose offloader? Boom. This is so much easier now. So we'll go into details with that. But thank you for holding up standards like that. That's really, really encouraging to hear. Here's another thing that oftentimes comes up is and where they're struggling, they're expecting their largely outpatient practice to be very similar to what they're seeing in the acute care setting. And that's throwing them off. Another part of this is, I believe what's happening now is that the RN role is so demanding that people are, it's more problem solution oriented, problem solution. And they don't really have the time to kind of break it up. Okay. That they really don't. So anyway. Okay. So I went over to the chat box and I could see, Brian has been in touch with you, and those insulin pages, use them when they're most helpful to your students, when you're going over diabetes or something along those lines. So I want to thank you very much for your time and attention. I'll hang around for a few more minutes and answer questions. More than happy to do that. I'm thrilled with the turnout tonight. Just thrilled with it. And I know you are incredibly busy people, and this is like for many of you, around the busiest time of the academic year too. And I thank you so much for honoring your students and for being here with me tonight. I see another question came in, so people are saying thank you. And next time we meet, which is in one more month, carryover questions, feel free. Ask away. Thank you, Brian, for holding down the fort. And by the way, please let your colleagues know about this. We really, really encourage anybody to join us at any time during the series. I'm sorry, Brian, I interrupted you.
No, I was just going to say you're very welcome, Dr. Fitzgerald.
We will see you all next month. Take care. Thank you.
All right, take
Good
care.
night.